Okay, folks, we are going to talk about inpatient coding. And I have my handy little notes right here, and I thought, instead of typing them out, I would not read them to you, but kind of go through them. So if I periodically look down, it's just because I'm trying to remember everything that I need to talk about. So anyway, when we're talking about inpatient diagnosis, the first thing and the most important thing is that principal diagnosis. And I know you've heard this before, but selecting that principal diagnosis is the utmost important thing that you have to do when you're coding, especially for inpatient, because everything in reimbursement is linked or done with that principal diagnosis. So each code is linked to a DRG, and we talked about DRGs in healthcare, or it must be healthcare reimbursement or just reimbursement. So anyway, each one of those principal diagnosis links to a DRG, and that whole DRG is going to give you the payment for that inpatient hospital stay, taking into account all kinds of different things, the bandages, the work that's done, the bed you're sleeping in, the lights, the everything. And so they were put together, these DRGs were put together to control spending. And so back in the day, they would let people just stay for as long as they wanted to let them stay, because they knew that the hospital was going to get more money. So the government came in and kind of went, well, that's not really fair. So here's a lump sum of money. This is what you get for this diagnosis and these other secondary diagnoses that may complicate things. And if you can take care of the patient faster and get them out the door, you're going to make a profit. If you cannot, then you're going to take a loss. So we need to make sure that principal diagnosis is accurate, because we need to get the best reimbursement that we can for the facility. Also remembering that principal diagnosis is the diagnosis after study. Different than the admitting diagnosis. The admitting diagnosis is what you came in for. I came in for abdominal pain. That's my admitting diagnosis. But after study, it was found out that I have appendicitis. So appendicitis is my principal diagnosis. That's why we have those lovely guidelines, which we've gone through the guidelines before for coding, but I'm just going to touch on them just a little bit. In inpatient coding, you only code signs and symptoms if there is not a definitive diagnosis. If there is no diagnosis, that is the only time that you can code signs and symptoms. And in inpatient coding, you do code diagnoses that are ruled out or possible or probable. So, for example, the example that I have here is, I come in with the abdominal pain. I have abdominal pain in my lower quadrant. I have a fever. I have nausea and vomiting. And the doctor runs some tests. Tests don't come back showing that I have anything going on with my appendix, but the doctor is still thinking, yeah, I think it's her appendix. And so what's going to happen for that, to code that, is the doctor is going to say, well, probable appendicitis. And so you're going to code appendicitis as if it were a definitive diagnosis, and you're going to code the symptoms that I came in there with. The pain, the abdominal pain, the fever, and all of those things. Usually what happens there is then the patient is transferred to an observation or something like that, or maybe transferred to another hospital or whatever, and then you're going to get your more definitive diagnosis. If you have two or more conditions that meet the guidelines of a principal diagnosis, you can choose either one. Usually what happens because of DRGs is you say, well, here's appendicitis, and here's, I also have you know what, I don't even know. I can't even think of anything. How about a fracture of the arm and a fracture of the leg? So either one of those can be the principal diagnosis, but you're probably going to go and look at the DRG for a fracture of the leg versus a fracture of the arm, and choose which one is actually going to give you the more money. If you have two comparative or contrasting conditions, you got to make sure that you code them. Let's see, they're coded as confirmed, right? So anyway, you have, here I am with this abdominal pain, and the physician says, well, it's either appendicitis or it's a hiatal hernia. And that's the diagnosis that they give you. Okay, so you code the appendicitis and you code the hernia until something is more definitive. This one right here, the original treatment plan is not carried out. You use the principal diagnosis as the condition, even though treatment might not have been carried out due to unforeseen circumstances. So in this case, I was admitted for an appendectomy. Something happened where my blood pressure went up or whatever, and I'm not going to have my appendectomy. So I'm still going to be, so it's still going to be coded as appendicitis, even though the treatment wasn't carried out of the appendectomy. You're also going to code the fact that I had something going on with hypertension or something to that effect. But if the treatment isn't carried out, you're still going with, why did you come to the hospital? If you go to if you're admitted to the hospital after an outpatient surgery because of a complication, it's that complication that is the reason why you are admitted. So you need to cut your complication code. And I don't know if I wrote this down here. I didn't. I can't remember what those codes are, what category those codes are, but you're going to code that complication as the reason why you're coming in. So you went in for outpatient surgery and you have a postoperative infection. So the reason for the admission is the complication of surgery, the infection. Let's see, we talked about uncertain diagnoses at the time should be coded as they existed. So again, you know, we're uncertain if it's actually appendicitis, but that's what the doctor said is appendicitis versus hiatal hernia. We're going to code both of those. I think that's it. There's a couple of other guidelines in there that, you know, you can go into. You should always have those guidelines around in case you have questions regarding the principal diagnosis. If you're really going through a chart and you're like, oh, I don't really know what it is that I'm, you know, supposed to be putting as that principal diagnosis. Your first place to go to is always the guidelines to see if there's anything that'll help you out in that aspect. Reminder that inpatient coding that you're using for the diagnosis, you're using ICD-10-CM, and for the procedures, you're using ICD-10-PCS. When you're talking about principal procedure, that is the procedure that is most linked for the treatment of why the person came in. So it's not diagnostic to. So in other words, it's not diagnostic, it's therapeutic. So in other words, if I had a scope done to see that I had appendicitis, that's not my principal procedure. The principal procedure is going to be the appendectomy that I'm going to have because I have the appendicitis. Also, ancillary tests such as your labs and your x-rays and things like that are not coded with ICD-10-PCS for inpatient. Probably talked about this in other places as well, but just a reminder again, when we're looking at an inpatient chart, right now we're looking at a workbook and snippets again. And I believe it's one of your final courses or maybe even an internship or something. You'll actually receive the full chart, the full record. So you'll be able to go through and really find and pick out exactly everything that you need. Excuse me, sorry about that. But I just want to remind you about those crucial documents that you want to look for. Your discharge summary is probably the biggest one. So make sure that you're looking through there. Your H&P, what you're looking in there is for any personal history or family history, things that you might need to code. And you're also looking for chronic conditions, like diabetes, hypertension, those kind of things. Those are the things that you're looking for when you're in the H&P. Progress notes is going to give you more specificity from the doctor on your diagnoses, and it might even talk about procedures that might have happened in the patient's room instead of via the operating room, things that you might be able to code as well. That didn't show up. Other things, labs in radiology. You do not code specifically off of labs in radiology, but you look for further information. So for an example, the doctor says that the patient has a UTI, and we all know that if there's an infection that needs to be coded, we need to try to find the organism that the infection, that is the infection, the organism involved. And so therefore what we're going to do is we're going to go to that lab report to see what organism it is. Was it staph? Was it strep? Whatever. So it's not like we're coding off of there, but we are just getting further information from those labs in radiology. Now, if you have a case where you're looking at a lab report or an x-ray or something, and there's something listed there as a diagnosis, but the doctor hasn't said anything about it anywhere else, that's where you're going to query the physician and ask, well, this is what is in the, in the lab results. Is this a viable diagnosis for the patient? You wouldn't just assume, that because a lab value was high or whatever, that they have something going on, hypokalemia, whatever. The last one that you really need to look at is your MARS, or your medication administration record. That's where all your meds are listed, and every single med has to have a diagnosis along with it. So when you're flipping through there and you see a medication for something and there's no diagnosis that's related to it, that, again, you're going to query the physician on that as well. Or if you are looking through that MAR and the patient is on a medication for, let's say, insulin or something, but nowhere else is it saying anything about diabetes, which that's kind of a little far-fetched. But just so you get my point, there's no diabetes, there's not diabetes listed anywhere. You know that you can code diabetes because this patient is getting insulin for it. So I think that's all. Just want to touch on a few things. Make sure that you're looking at those guidelines. And if you have any questions on inpatient coding, you know where to find me. I think that's it. All right. Bye.